as I was saying, I am a lab rat, so this is going to be a little bit of a change of focus on the topic here. I'm going to take you through a little bit of our preclinical development for a bicistronic CAR, which we are using to try and address some of the limitations that we've encountered in our first couple of clinical trials using CAR T therapy. So for those who aren't familiar with it, chimeric antigen receptor T cell therapy, or CAR T cell therapy, basically, we are taking the patient's T cells and engineering them to redirect them towards a target of our choosing. So instead of relying upon the native T cell receptors and what they're going to be able to find in the tumor, we transduce the T cells with a lentivirus that contains our CAR construct with a scFv or other targeting moiety on the extracellular portion. So this is based off of the CD19, which was the original approved one. You can see here your T cell is now expressing anti-CD19 scFvs, allowing it to recognize tumor cells, bind to them, and engage them through a normal T cell mediated cytotoxicity and kill the tumor. And so this, as I'm sure as everyone is aware, has had some very nice successes in the liquid tumors, starting with the approval of Kymriah back in 2017. And as Charles mentioned, there's Carl June, who's really been a pioneer in this field. So we've been trying to build off of their success and expertise and really trying to apply this into solid tumors, and specifically glioblastoma. I think for this audience, I don't really need to spend any time on glioblastoma, but I did want to emphasize, as I'm sure you all are very intimately aware, about the incredibly invasive nature of it. And no offense or slight intended to all of the surgeons on the line or in the room, but we know that at least with current techniques, this is a tumor that cannot be cured surgically, nor with the established standard of care with radiotherapy and chemotherapy, that we need targeted approaches, precision approaches that are going to be able to get those invasive cells that escape the bulk of the tumor and are what drive regrowth and relapse of the tumor. I'm biased because I'm at Penn, and Penn obviously is a leader in the immunotherapy realm, but I really do think that this redirected immune system approach has the potential for a lot of success in this area. So Dr. O'Rourke led our first CAR T trial in GBM here at Penn, which was targeting EGFRV3 using a very specific scFv against EGFRV3. So it's a phase 1 study, so it wasn't designed or powered to really demonstrate efficacy, but instead was trying to demonstrate safety of the approach, and that with the delivery of CAR T cells through peripheral administration, you could actually get them into the tumor. We chose EGFRV3 as the target for a variety of reasons. Obviously, with this T cell mediated approach, you need extracellular targets so that you can bind them on the exterior of the cell. And so EGFRV3 is nicely extracellular. It is tumor specific, so there wasn't concerns about on-target off-tumor toxicities. And it's an oncogenic target as well, which we were hoping would give us a sort of a foot up in terms of blunting or delaying the regrowth of the tumor by getting rid of cells that really had the oncogenic drive. It's not a perfect target, right? Not everybody is expressing EGFRV3. Even in patients that are expressing EGFRV3, there's PACG expression throughout the tumor. And even though it is demonstrated to be oncogenic, there is a very unclear clinical significance. I think my favorite was a paper that said if you survive less than a year, EGFRV3 expression has no impact on your survival. But if you survive greater than a year from diagnosis, EGFRV3 is a negative prognostic indicator. And so having to go through those sort of statistical gymnastics to find significance really highlights that it's a complicated target with a really unclear clinical significance. That being said, with the first trial, we did see a nice loss of target antigens. You can see here pre-CAR T and post-CAR T levels of EGFRV3, and there was a global decrease in the levels, some of them even going down to not detectable across all of the patients. However, we also noticed that amplification really didn't seem to be affected. So you can see here EGFR amplification is really not following any distinct pattern. And one of the issues we felt this highlighted was the fact that our scFv or our CAR T cells were very specific to EGFRV3. And so even though there are other EGFR alterations occurring with them, they were very selective in what it was that they were targeting. The other issue that arose was this wave of tumor microenvironment immunosuppression. So this is immunohistochemistry-based assessments of a number of different cytokines, both again pre-infusion and post-infusion. And you can see the ones that I've highlighted here, FOXP3, which marks our T regulatory cells, and then a bunch of immune checkpoint markers, IDO1, PDL1, PD1. They all seem to increase post-infusion, suggesting that there's this response from the tumor and the tumor microenvironment that really ends up shutting down the immune activity in the vicinity of the tumor. And you can just see here on the IHC, a very dramatic difference between pre-infusion PDL1 levels and post-infusion PDL1 levels. So the takeaways from this first trial were that while it was safe, which was fantastic to observe, and we were able to get CAR T cells into the tumor from peripheral administration, there were two significant roadblocks to really getting some successful progression-free survival and overall survival increases. The first being target heterogeneity, which is what I'll focus on today, and then the second being this immunosuppressive microenvironmental response. Just to briefly put it out there, our second trial, which we will be submitting the paper with the results of it actually hopefully this month, we decided to combine the same CAR construct, so again targeting EGFRV3 with pembrolizumab, so looking at the PD-1, PD-L1 immune checkpoint blockade axis or immune checkpoint axis, trying to block some of that immunosuppression and allow the CAR T cells to do their work. But what I wanted to talk more about was how we were going to go about addressing target heterogeneity. So there are a variety of approaches that you can take with T-cell engineering or with cell engineering to try and expand your targeting repertoire within the tumor. And we really wanted to look at this option of making it polyvalent, or at least starting out with bivalent, so that instead of our T-cells expressing just a single monovalent CAR, which is what the initial trials were done, they would be expressing two different CAR constructs, allowing you to target two different targets on your tumor. So there are two different ways that you can really go about doing this, one being an AND logic gate, the other being an OR logic gate. So with an AND logic gate, you need the presence of target 1 and target 2 in order to get full engagement and activity of your T cell. We really wanted to focus on the OR, where presence of target 1 or the presence of target 2 would be sufficient to cause T cell activation and killing. The thought being here that this will allow us then to engage cells that are expressing either or target, and hopefully allowing us to kill more of the tumor cells within the tumor itself. So the targets that we chose were EGFR and IL-13 receptor alpha 2. We have done our trial focused on EGFRV3. NCI has also conducted an EGFRV3 targeting CAR T trial. City of Hope has a significant amount of experience targeting IL-13 receptor alpha 2 with a CAR construct. So these are targets that are known in the literature and sort of have been established. This is a dual stain IHC looking at both EGFRV3 and IL-13 receptor alpha 2. So the brown is the IL-13 receptor alpha 2 and the red is EGFRV3. And what you can see is that while there are some cells that seem to be co-expressing, there are also a distinct number of cells that are expressing one or the other. And that obviously is preferable, having orthogonal targets where the expression of target 1 has no bearing on whether it expresses target 2, and really allowing us to try and capture more of the tumor cells as being target positive. So this is based off of cell line establishment and evaluation. It's a little bit complicated, but just briefly, if you look on the left side here, this column are EGFRV3 positive cell lines. These are negative. And then the color coding is the level of IL-13 receptor alpha 2 expression. And you can see that if you count up either the ones that are V3 positive or expressing a nice amount of IL-13 receptor alpha 2, 9 out of the 10 lines here evaluated would be considered positive. On the right side, this is looking at amplification as opposed to V3. And here, 6 out of the 10 lines were shown to be positive for one or both of our targets. So we felt like these two targets taken together would really do a nice job at expanding the repertoire of what we're able to target with our CAR T cells. But we didn't want to just target EGFRV3. It is, the most common alteration after amplification found in the EGFR family in GBMs, but there are a significant number of other alterations, actually also including amplification. So you can see this is based off of an internal cohort here at Penn, showing amplification. Here's our EGFRV3, but there's a number of extracellular mutations that are found either coexisting with V3 or independent, that are extracellular and therefore amenable to CAR T treatment, and also in most cases are tumor specific. And so we happened across an antibody in development called MAB806, which happens to show some nice cross reactivity to EGFR. So this has actually been in trials I'm sure people are familiar with. It was an antibody drug conjugate, and it's actually in pediatric CNS tumor CAR T clinical trials out of Seattle Children's, I believe. But we were able to show that the 806 binds to a significant number of EGFR alterations. So this is variant 3, variant 2. I apologize for the numbering scheme as it gets a little different whether you have the signaling sequence in there or not, but these were a number of those extracellular missense mutations that we had previously identified. And although it doesn't show it nicely here, it actually also binds nicely to tumor-associated wild-type EGFR. And I specify tumor associated because it's wild type and that there's no mutations in the sequence, but there are alterations in the trafficking kinetics as well as some of the post-translational modifications if you compare it to something like astrocytes or keratinocytes. So we found that this 806 construct would recognize wild type on our tumor models, but didn't lead to such significant killing with normal physiologic wild type such as astrocytes. And so this was a publication from one of my postdocs. She looked at a whole bunch of different EGFR mutations and found in all cases, the pink here being our 806, and this gray-green line is actually cetuximab based, which is our positive control. So 806 did a very nice job with killing throughout, regardless of which of the targets was present. Cetuximab looks very nice and very exciting, but in my take on it, cetuximab will bind to you if you just think the word EGFR, whether or not you're actually expressing it. And so from a CAR T perspective, it seemed like it would have a lot more potential for on-target off-tumor toxicity, which is why we've avoided it. And in the interest of time, we'll just skip beyond that. That was just a very heterogeneous model. So that's our EGFR focused or EGFR targeting construct. So we then wanted to look at the IL-13 receptor alpha 2. So this is work from another postdoc in my lab, Dr. Yin, who characterized two different humanized SCFEs, HU07 and HU08, which did a nice job at recognizing, binding to, and killing cells expressing IL-13 receptor alpha 2. And so using those two constructs, we put them together into a single plasmid. And this is looking at T cell activation. So this is CD4 positive T cells, CD8 positive T cells. CD69 is our metric of T cell activation. And what you can see is that if you are expressing target 1, target 2, or both targets, in each case, the blue line here representing our bicistronic CAR shows a nice amount of activation. And you can see here 806 recognizing the EGFR positive cells, but our IL-13 construct did not, and vice versa with the IL-13 receptor alpha 2 positive line. So this was a nice indication that our bicistronic T cells are able to recognize the presence of either target and both targets become activated. In addition to CD69 for activation, we like to look at intracellular cytokines to show that the T cells are actually engaging their cytotoxic mechanisms. So this is interferon gamma, IL-2, and TNF alpha. And you can see in each case, again, the blue line here representing our bicistronic CAR. While it's not always the highest level, it is elevated in every condition, whether you have target 1, target 2, or both targets present. This is just T cell activation. So of course you need to look at killing. So this is a in vitro killing assay. This is a different E to T ratios, so increasing number of T cells per target cell. And you can see that in each case compared to untransduced T cells, we're getting nice levels of killing. Again, whether you're positive for target 1, target 2, both targets. And this is a D270, which is a patient-derived xenograft line that again is present in or double positive for both. And we put this into animals, we again are able to get significant tumor control. So this is again using the D270 line. And so, I mean, this is the sort of standard developmental approach that we take where we demonstrate T cell activation in vitro and then take it in vivo to see that we're actually getting killing in an orthotopic or in this case, subcutaneous tumor model. And so today's talk was actually very timely because we was significant more safety and toxicity data behind this, but we actually just had our site initiation visit at the beginning of this week for opening up this bicistronic trial, and we anticipate enrolling patients by the end of the month. So we really feel like the use of a polyvalent CAR construct is going to expand the number of tumor cells that it's going to be able to kill within each patient, as well as actually expanding the number of patients eligible for receiving those CAR T cells. The targets that we've chosen are relatively unrelated to each other, and again, sort of does a better job at killing more of the tumor cells, leaving less chance for tumor escape through antigen loss. And then, as I said, we're starting the clinical trial enrollment, and so very excited to see what we're able to do with this actually in patients. And so with that, I wanted to thank everyone who put their work into it, and again, thank you very much for giving me the opportunity to chat.
Oh, that was a tour de force. Thank you so much, Seb. Is that trial, did you say, are you using a checkpoint inhibitor in addition to the bicistronic CAR T?
No, so the checkpoint inhibition actually did not work. So combination of PD-1 with the monovalent CAR T cells led to no increased survival in a de novo GBM population. We did concurrent administration of the pembro with the CAR T cells, so for logistical reasons, so the patients wouldn't have to keep coming back in. And later evaluation of product, I think PD-1 positivity is actually necessary for CAR T cells to engraft and expand. And so I think we sort of shot ourselves in the foot. And if we had separated them by 1 or 2 weeks, or if we had done PD-L1 targeting on the tumor instead of PD-1 on the T cells, we would have had a better opportunity. But we have a couple projects ongoing in lab about how better to armor the CAR T cells against this immunosuppression. And so once we demonstrate safety of our bivalent Bicistronic construct, we are going to be adding in some modifiers to make them more resistant to immunosuppression.
Great, wonderful talk. Well, hopefully down the road, the stuff that we're doing in our group will eventually lead to some new targets too. So hopefully,
I hope so.
Call in a couple of years. Thanks again, wonderful work, and I appreciate it. The next speaker is Tessa Desrochers, who